HIV in pregnancy earlier was looked after by NACO purely. There was no such separate program which was so comprehensive. There was NACP, that is National AIDS Control Program, but now we have something more that was given or that was termed in 2024. So now, as per the latest 2024 guidelines that I've taken from NACO itself, it's a beautiful guideline. It is very vast. It's a 290-page PDF, and I've taken the best parts from it that are important for you. Now it is called as EVTHS. It's a part of NACO itself. NACO is National AIDS Control Organization, but this is the program that they have started in 2024. The full form is Elimination of Vertical Transmission of HIV and Syphilis. So the biggest change here has been, if you see their guidelines, it is they also mention how do you manage syphilis. And no, not just syphilis in pregnancy, but even syphilis as a standalone STI, STD, whatever you call it. This guideline also tackles with that. So this is a 2024 update. If you go into that update, the reason it's such a vast update and vast document is because it also has a lot about syphilis. But syphilis is not going to be a discussion for today. If you want, if you message on the Telegram group, then I will make a video for syphilis as well from the same guidelines. But today our focus is going to be purely on HIV. So when I talk about HIV, I know a few basics that I've been learning a time and again since my second year of MBBS through my pathology. One is there are two main types, HIV-1 and HIV-2. Whereas HIV-1 is the more prevalent one. Almost 90% of the cases are going to be HIV-1. It is also more infective, and most of the patients that you will find are going to be of HIV-1. And in fact, all our main first line drugs, they are also going to be very effective against HIV-1 in comparison to HIV-2. So that is the first difference. And of course, in pregnancy as well, the same thing follows suit, that HIV-1 is going to be much more common than HIV-2. So in India, we have a test and treat policy. Basically, we test and we immediately start the treatment for them. But before understanding the test and treat and everything, how do we treat them, we should first know what are the risk factors that increase the likelihood of vertical transmission. So what are the risk factors that increase the chances of vertical transmission? I would want to learn that first. So there are going to be maternal factors, there are going to be obstetric factors, and there are going to be fetal factors. So in maternal factors, one of the biggest risk factors for increase in vertical transmission is going to be recently diagnosed HIV. Why? Because if it is recently diagnosed, very recently, then probably the female is someone who has not yet started her ART, that is antiretroviral therapy, or she has started it but it has not got an adequate amount of time. Her body has not got adequate amount of time with the ART to reduce its viral load and keep the CD4 counts high. So it is very likely that the viral load is going to be through the roof. It is going to be quite a lot, and also that the CD4 count is going to be possibly low. So a recent diagnosis is merely because either the treatment is not started or it has been started but it has not been long enough for it to have acted efficiently. Next, the same thing that the recent diagnosis would do if there is a high viral load. So a high viral load can be because maybe probably because it's a recent diagnosis, or it can be because your therapy is not proving to be effective. Or even more common is your patient is not compliant with it. Why? Because this drug, all these drugs, in fact, of ART, they have very high and very significant side effects. So patients tend to lose out on the compliance of it. And the bigger reason for losing out on compliance is not the side effects, but the initial phase of HIV and AIDS as well, wherein you don't get those symptoms that will make you fear it. Those are what happen a few months or years down the line, once that asymptomatic latent period is gone. So patients tend to take these treatments lightly and they tend to be poor with their compliance. So poor compliance or the therapy not being effective enough will lead to a high viral load. Apart from that, of course, if there is any resistant strain, HIV2 being one, it is not technically resistant, but slightly resistant. So if there is a resistant strain that has infected the mother, or it can be because she has a WHO AIDS class 3 or 4. So basically she has advanced disease. Stage 4 are all opportunistic infections of every system. So if there is any opportunistic infection that she has gotten, or AIDS defining illnesses is a better word as well, if she has gotten any one of them, then she falls directly into stage 4. Stage 3 is having a lot of pre-malignant and प्री एड्स डिफाइनिंग इलनेस वाले सिम्टम्स बहुत सारे हैं, सिम्टम्स एंड साइंस. तो वो दोनों में से अगर है, देयर इज अ हाई रिस्क दैट शी इज गोइंग टू ट्रांसमिट इट वर्टिकली. Apart from that, if she has any STIs, sexually transmitted infections, any active STIs. Why? Because if there are any sexually transmitted infections that a female is harboring currently, and if she's about to deliver vaginally, then remember that any infection is also an inflammation, and any mucosal inflammation, the vaginal and the genital tract mucosa is going to be inflamed. That is going to increase, or that is going to increase the space between the epithelium. Basically, it is going to increase the exposure of the STI to the fetus. So if you're going to attempt a vaginal delivery, it is very likely that the fetus is going to consume, or probably is going to have it all over his body while delivering vaginally, and that can lead to the possibility of the fetus getting affected as well. Also, that inflammation is not only going to expose the fetus to the STI, but a bigger problem is here going to be that the fetus is going to be exposed to the HIV virus that is being expelled out from that lesion or from that STI, that infection, that papule, that ulcer. The HIV virus is going to be freely coming out from there, and the baby's face is going to come in contact with that. So it increases the chances of the fetus getting HIV during delivery. Apart from that, if the female is malnourished, of course, if she's malnourished, then she's going to have poor immunity. Poor immunity is going to reflect in the form of high viral load and low CD4 counts, and she's going to have higher stages of AIDS much earlier than a well-nourished patient. And lastly, if she has any breast abnormalities or breast pathologies, this is more important when she is going to be breastfeeding, because when she's breastfeeding, if she has something like breast abscess, or if she has cracked nipples, mastitis, cracked nipples, basically it is same like STI. If there is any inflammation on the area of breast, in the area of areola, and the fetus is trying to drink it, then there is going to be viral shedding, and the fetus is going to consume HIV virus. So these are the maternal high risk factors.